So the first three lectures were really organized in a way to help you understand the different parts of the CSO and Scottish Government streams of research available to you. We're now going to move on to two clinical presentations and pieces of research that were covered during the COVID pandemic. The first of these addresses disc hemorrhage, which is a fairly small but regular group of patients that are referred from primary to secondary care. And increasingly, with people living longer, more of us being on anticoagulation and peripheral vascular disease and difficulty with seeing patients in hospital, it becomes quite important to triage these patients appropriately. And James Hazelwood, who is an ophthalmic trainee at the Pavilion in Edinburgh, is going to present a piece of work on prioritizing and triaging disc hemorrhage patients. Thank you.
Good morning, and thank you for the opportunity to present today. My name is James Hazelwood, and I'm an ophthalmology ST1 based at the Pavilion in Edinburgh. Today I will present the paper, The Positive Predictive Value of Optic Disc Hemorrhages for Open Angle Glaucoma, on the behalf of my colleagues listed on the title screen. As we know, glaucoma is a common cause of irreversible blindness, which is known for asymptomatic visual loss. Its incidence increases with age and currently accounts for around 20% of hospital eye service referrals, most commonly from community optometrists. Given the increasing age of the population, the number of patients requiring management for the glaucoma is increasing the pressure on glaucoma services. When we think about referrals for glaucoma, it's important to assess their positive predictive value. The advantages of a high positive predictive value in a referrals process allows early referral, which enables prompt treatment and ultimately limitation of the visual loss in the patient. In low positive predictive value referrals, inappropriate referrals lead to high first visit discharge rates and a reduced ability of the clinic to see, assess and treat those in need. In Scotland, the General Ophthalmic Services contract entitles all Scottish residents to free eye examination. This is for every 2 years in those of the general population and every year for people who are over 60, have diabetes, glaucoma, or are over 40 with a family history of glaucoma. This is felt to allow greater equality and ease of access to eye care, and based on the fact that the optometrist business model is less dependent on sales in comparison to England, where eye examinations are only free for those under 16, over 60, or those with an eye condition. The Scottish GOS arrangements are also unique within the UK and offer a wider range of clinical tests than elsewhere. Specifically, they mandate glaucoma detection strategies, which has been found by Ang and El Assal et al. To improve timeliness of referrals and improve positive predictive value of glaucoma referrals. However, the GOS contract does not give specific advice regarding the suitability for referral to hospital or primary care monitoring in those with glaucoma. The Scottish GOS contract improves the quality of glaucoma referrals by mandating examinations, as we discussed, including applanation tonometry, dilated fundoscopy, slit lamp biomicroscopy, and threshold visual field testing. In addition, the GOS contract is thought to have contributed to the upskilling of optometrists, with a larger proportion of Scottish optometrists undertaking prescribing training in comparison to England, with support from the Scottish Government, and an improved efficiency, whereby the year-on-year increase in hospital ophthalmology costs has been lower in Scotland than in England since its introduction. Bruce and Tatham in 2016 found 79% of optometrists were interested in managing primary open-angle glaucoma in the community, though they did note a few barriers, notably the remuneration for this examination and the communication with secondary care. The guidelines for referral of a patient with glaucoma to the hospital eye service are set out by the SIGN 144 guidelines, who advise referral of all patients, irrespective of IOP, if they have suspicious or glaucomatous appearances of a disc in either eye, a reproducible visual field defect that's consistent with glaucoma, or a risk of angle closure. They should also refer those with an IOP of over 25, irrespective of CCT, and IOP under 26 and a CCT of under 555 micrometers if they are under 65 years old. Additionally, they should also refer optic disc hemorrhage irrespective of the absence of other glaucomatous features. And this paper assesses that, given the increasing demand for glaucoma clinic, can we optimise the positive value of community ophthalmology glaucoma referrals by studying those who are referred with disc hemorrhage. So disc hemorrhages are characteristic linear hemorrhages perpendicular to the optic disc that are most commonly found in the superior or inferior temporal margins of the disc. They cross from the optic disc into the adjacent retinal nerve fibre layer, and they are known to have a prevalence of 0.6 to 1.4% in the general population based off the beaver dam and blue mounted eye studies, though the prevalence in glaucoma has been noted to be higher, around 4.4 to 17.6%. Importantly, disc hemorrhages are known to be a risk factor for both glaucoma and glaucoma progression, as discussed in the collaborative normal tension glaucoma study, hence why they are referral criteria in the SIGN guidance. So disc hemorrhages are thought to be explained by the vascular hypothesis, whereby the vascular dysregulation and endothelian changes that are implicated in the vascular hypothesis of glaucoma are the cause of the development of the disc hemorrhages. As we said, the prevalence of these in glaucoma is up to 10 times that of those without glaucoma. However, disc hemorrhages can also be present in PVD, hypertension, diabetes, and in those using both antiplatelet and anticoagulants. Few studies have been found to assess the positive predictive value of disc hemorrhages in referrals to a glaucoma service, one of the few studies being Wang et al. In 2006, who found a 20% positive predictive value rate in a rural Chinese population. So as such, this study was conducted to assess the PPV in a Scottish population. So from June to November, 1,070 consecutive glaucoma referrals were screened, and they were excluded from the process for reasons such as missing a referral letter, if the referral was not from an optometrist, if they had a history of a secondary glaucoma, if there was suspected angle closure, if the patient DNA'd the clinic, there was a lack of clinic information, and ultimately this left 618 patients, of which 52 had a disc hemorrhage. So these patients were then seen in clinic either by a consultant or an experienced hospital optometrist, where they were assessed for their history, had a fundus and disc examination, Goldman applanation tonometry, gonioscopy, Humphrey visual fields, and an OCT of the retinal nerve fibre layer. And this gave 4 main outcomes for these patients. So firstly, they could be diagnosed with open-angle glaucoma, and the diagnosis or not of this represented the primary outcome of the study. They could be diagnosed as a glaucoma suspect, whereby they had a suspicious disc appearance or Fields result, but not enough to begin treatment. Or they could be diagnosed with ocular hypertension with an IOP greater than 21, but with no evidence of glaucoma with an open angle. Or they could be discharged at the first visit without any treatment needed for glaucoma or for ocular hypertension, generating a first visit discharge rate, which was the study's secondary outcome. So firstly, some demographic results regarding the disc hemorrhage group, of which there were 54 patients. These patients were significantly more likely to be older and more likely to be female, in agreement with previous literature. They had lower IOP, thinner CCT, and were less likely to have a visual field defect or a suspicious disc. They divided these disc hemorrhage group into those who were referred for disc hemorrhages alone, disc hemorrhages with another feature of glaucoma, and disc hemorrhages with 2 features of glaucoma. So of the 54 patients referred with a disc hemorrhage, 29 of them were diagnosed with open-angle glaucoma on the first visit, giving a positive predictive value of 53.7%. However, as you break down this population into their component parts, a pattern begins to emerge. So in those who were referred with disc hemorrhage alone, only 23.8% of them were diagnosed with open-angle glaucoma on the first visit. If they had 1 feature of glaucoma and a disc hemorrhage, they had a PPV of 55%. If they have disc hemorrhage and 2 features of glaucoma, then they have a PPV of 92.3%. This is in comparison to when you take into account all 618 participants in the study, the PPV was 59.4%. So Almost as expected, the positive predictive value increases as you increase the features that are suggestive of glaucoma in the referral. However, interestingly, the first visit discharge rate is also the reverse of this. So here you can see a graph of the first visit discharge rates. So overall, for all 618 people, the discharge rate was 25.9%. And this is similar for those who were referred without a disc hemorrhage, which was 25.0%. However, in those who were referred with only a disc hemorrhage as the reason for their referral, the first visit discharge rate was 57.1%. As you can see from the trend with the first three columns, as you add a feature of glaucoma, the first visit discharge rate falls until, with disc hemorrhage and two features of glaucoma, the first visit discharge rate is 0%. So the inverse of the positive predictive value trend. Interestingly, a disc hemorrhage did not increase the odds of diagnosis of glaucoma in this referred population with an odds ratio of 0.88, but with confidence intervals of 0.4 to 1.96. So, as we already covered, the current sign guidelines recommend a referral for assessment if a patient has disc hemorrhages, regardless of the presence or absence of other signs of glaucoma. In this study, in the disc hemorrhage group, 53.7% were diagnosed with glaucoma on the first visit. However, the majority of these also had other signs of glaucoma in addition to their disc hemorrhage. As we recall, if they had a disc hemorrhage and two other signs, then the positive predictive value was 92.3%. However, if they were referred for only a disc hemorrhage, only 23.8% were diagnosed with glaucoma. Interestingly, the positive predictive value overall for glaucoma referrals was very high at 59.4%. This is much greater than the around 30 to 37% that is reported in the previous literature, and is possibly related to the Scottish GOS contract and the more detailed investigations that are able to be performed prior to referral. When reviewing positive predicted values, it's important to remember that the positive predictive value is influenced by disease prevalence in the population. So if you took a test with 98% sensitivity and 98% specificity and used it in a population with a disease prevalence of 2%, it would act with a 49% positive predictive value. However, in a population with a 5% prevalence of the disease, it would have a 79% positive predictive value. And for context, in glaucoma, there's around 1% prevalence for those over 40 and 5% for those over 75. So as we've already covered in this study, the glaucoma prevalence was 60%, with disc hemorrhage positive predictive value acting at 53.7%, and an isolated disc hemorrhage at only 23.8%. If we correct these values, if you like, for a population with a population level prevalence of glaucoma, then the positive predictive value of a disc hemorrhage reduces to 1.6%, and an isolated disc hemorrhage positive predictive value is only 0.4%. To negate this effect, we can use a likelihood ratio, which is the effect that a finding has on the likelihood of the presence of a disease, as these are independent of disease prevalence. For this population, overall, assessing patients in a glaucoma clinic, isolated disc hemorrhage decreased the probability of the glaucoma diagnosis with a likelihood ratio of 0.22, confidence intervals of 0.08 to 0.59. However, it's important to bear in mind that this is not the same as finding an isolated disc hemorrhage in an optometrist screening, reducing the likelihood of glaucoma, as this represents a different population, so the link between the two cannot be made in that sense. So from this population, we know that isolated disc hemorrhages have a positive predictive value of around 24%, though in the general population this could well be much lower. And whether an isolated disc hemorrhage represents a reasonable criteria for referral largely depends on the setting from which the referral comes. So given that the aim of referral and subsequent treatment of glaucoma is to reduce the lifetime risk of visual loss. A disc hemorrhage with no other features may be suitably low risk of progression to monitor in the community. If the facilities are available, monitoring the isolated disc hemorrhage in the primary care setting may be valuable in reducing the demand on hospital eye glaucoma services. However, given the PPB of nearly 24%, it would be prudent to ensure that this person could have further testing, as it's likely that those referred with disc hemorrhage alone, but were diagnosed at the clinic, had other signs of glaucoma that were detected in clinic, either through expert examination or via performing tests that are not available to the referrer. As such, one could propose some possible patient pathways using this data, whereby a patient undergoes a routine eye exam, and on finding of a normal examination is clearly retained in the community, having their eye exam within the next year or 2 years, depending on their characteristics. In the second scenario, where an isolated disc hemorrhage has occurred, one could consider monitoring this patient in the community if this person represents a low risk for development of glaucoma or progression, and the optometrist has suitable training and facilities available to do so. And then obviously in the third outcome, where there is glaucomatous clinical features, including or not including a disc hemorrhage, then as before, the patient would be referred to the hospital eye service as per the current SIGN 144 guidelines. So this study has a few key limitations. The first being that it is important to consider that the disc hemorrhage positive predictive value may in fact be an overestimate, as data about those with a disc hemorrhage alone who were not referred by the optometrists because they were deemed to be at low risk was not captured by the study. This introduces selection bias, and ideally a primary care-based study would capture this data to better inform the policy regarding the referrals of disc hemorrhage alone patients. Secondly, no analysis was performed of whether those discharged with a disc hemorrhage alone were then later re-referred to the service. One would expect this to occur in some of these patients, as we know that disc hemorrhages represent a risk factor for progression of glaucoma, and future work could monitor this specific subgroup for representation to the hospital eye service. So, in conclusion, this study has demonstrated that disc hemorrhages are a common reason for referral to the hospital glaucoma clinic, representing 9% of referrals. It has also shown that isolated disc hemorrhage has a positive predictive value of 23.8% in this cohort, which is roughly in line with previous literature. However, when corrected for prevalence rates of glaucoma within the general population, this falls to 0.4%. Therefore, in summary, the protocol for a patient referral who has an isolated disc hemorrhage may ultimately depend on local arrangements, equipment, and optometrist ability to investigate and monitor for future glaucomatous changes. However, if this was performed successfully, this could improve both the positive predictive value of referrals and system efficiency. This is a list of references discussed throughout this presentation. Thank you very much for your attention.
Thank you, James, for that nice and succinct presentation. And I think it's a really good example of a group of patients who we perhaps had a reasonably low threshold to see in hospital before, but going forwards, we really do need to rethink. And I particularly like the flow chart at the end. Thank you. And a few questions in connection with that presentation.